A 34-year-old female presents with pain, swelling, and subcutaneous nodules in both hands. I am showing you a posteroanterior radiograph of the fingers. Please describe the findings.
The radiograph demonstrates a classic lace-like pattern of lucency and coarse trabulation in the middle and distal phalanges of the third and fourth digits, with associated soft tissue swelling. The joint spaces are preserved, and there is no periostitis.
What is your primary diagnostic concern?
The combination of a lace-like trabecular pattern and well-circumscribed cystic lesions in the phalanges with preserved joint spaces is characteristic of osseous sarcoidosis.
What is the underlying histology of the lesions causing this lace-like bone resorption?
The bone resorption is caused by the infiltration of non-casating granulomas in the bone marrow, which scallop the cortex and coarsen the trabecular pattern.
How common is bone involvement in patients with sarcoidosis, and what clinical findings are typically present?
Bone involvement is relatively rare, occurring in about 5% of sarcoidosis patients. It is almost always associated with cutaneous lesions, particularly lupus pernio or subcutaneous nodules.
What other organ system is classically abnormal in 80% of patients with osseous sarcoidosis, and what would you see on imaging?
The chest is classically abnormal, typically demonstrating bilateral hilar and mediastinal lymphadenopathy, with or without parenchymal interstitial lung disease.
How does sarcoidosis of the hand differ radiographically from psoriatic arthritis and joint infection?
Sarcoidosis typically preserves the joint spaces and lacks periostitis, bone proliferation, or cartilage destruction. Psoriatic arthritis and infection show prominent joint space narrowing, erosions, and periosteal reaction.
What are the common skeletal complications associated with the treatment of chronic sarcoidosis?
Long-term corticosteroid therapy can lead to secondary osteoporosis and osteonecrosis. We must monitor bone mineral density and vitamin D levels.
Finally, what are your clinical management recommendations?
I recommend referring the patient to a rheumatologist or pulmonologist for systemic evaluation, including a chest radiograph and pulmonary function tests. Treatment typically involves oral corticosteroids or methotrexate.